Welcome to another episode of Three Plastic Surgeons and a Fourth. And as always, I have my esteemed colleagues, Dr. Salvatore Pacella from La Jolla, California. His Instagram handle is at San Diego Plastic Surgeon. Dr. Lawrence Tong from Toronto, Ontario, Canada. And his Instagram handle is at Yorkville Plastic Surgery. And of course, still missing, but due to return very soon, is Dr. Sam Jajurakar from Dallas, Texas, and his Instagram handle is at Sam Jajurakar. Our topic today is about a single surgeon, basically a surgeon who has done over 1,200 breast augmentations and over 12 years. And he recently published his experience in PRS Global Open. And I thought it would be a very interesting discussion to talk about what he found were his problems, issues, characteristics about his breast augmentation, and then compare them a little bit to ours and see if what we do jibes with what Dr. Paolo Montemurro from, I think it's Sweden. That's such a Swedish name there. Does. And see if if we agree or disagree with what Dr. Montemurro has done in his extensive experience. But before we proceed, Dr. Tong, if you could give us the disclaimer.
My pleasure. This show is not a substitute for professional medical advice, diagnosis, or treatment. This show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something in this show.
So the study evaluated 1,200 of his patients, and his mean age of these patients was 31 years old. And he followed them for at least 6 months after surgery. And he is going to report, and he reported all of the different statistics and characteristics of these patients and the implants and what his outcomes were like. And let's just start with the complication rate. His total complication rate was listed at 7.1%. And the most common complication he reported in his series over from 2009 to 2021 was capsular contracture, which he reported occurred 2.64% of the time. What do you think about that complication rate as well as capsular contracture complication rate?
Well, he's only following the patients for 6 months, right?
Mean was 18, minimum 6, average 18 months.
Oh, okay. 18 months. Okay. So, I mean, it sounds relatively low from the standpoint of capsular contracture, I think. I think if you look at the literature, I've heard the rate anywhere from 10 to 33%, I've heard. And so I commend him that rate is very low. I'm curious to know what he rinses the implant with, what his hematoma rate is, what, the size of the implants, the texture of the implants, submuscular, subglandular. These are all kind of factors that have been shown in the literature to affect the risk of cap.
I think that, his rates are very good. Capsular contracture, I would say, aside from maybe cosmetic issues, is probably, the most common type of complication. I would say, and I'll ask you guys, if you see capsular contracture in a patient, would you say it's usually within that first 18 months of surgery? Because in my experience, yes, I would say it's within the first year. You would generally see it, but I would say that, capsular contracture rate in my hands is generally fairly low. I do probably 99% of my breast augmentations under the muscle, and I think that by far is the most important factor. But Sam or Sal, what is your common sort of, or most common mode or way that you perform the surgery?
For me, I do it almost a majority of them through an inframammary incision, so that's under the breast, not around the areola. And I would say almost all of them are under the muscle, or what we call dual plane, which is what this guy reported. He reported 96% of his implants were placed dual plane, and maybe 3.7% were subglandular. So I don't know if that jives with you, Sal, in terms of what you do.
Yeah, I would say that probably a good 95% I do, just like you two guys, dual plane underneath the muscle. I think that's a very low rate of any complications. Um, in general, I think my complications or my capsular contracture rate is relatively low. And I think, I've never seen this really reported in the literature, but I have a distinct feeling professionally that one of the risks of capsular contracture is the size of the implant. I have found that when patients come to see me, and secondarily, and they have capsular contracture, it's usually a very large implant stuffed into a very small lady, and that to me can contribute to issues. So in general, I would say that my implant usage is very small to modest size, very kind of yoga mom type of appearance. I don't see massive breasts. In the subglandular implants, I do. It's usually in someone who is very exceptionally fit, who is worried about a pectoralis animation deformity. And invariably in those types of patients, I'll use some sort of additional tissue support, like a mesh.
He does mention that he found using a funnel reduce the risk of capsular contracture. And that, I think, I like both of you, my occurrence of capsular contracture is pretty rare. But I am also, and I'm sure you guys are also, pretty fanatic about no touch, about the antibiotic and the betadine use. All of those things are crazy important to me when I do a breast implant placement. And I think that those are things that have been proven in the literature to help. The large size implants, that's very interesting. What would you consider large, like over what volume? His mean implant volume here was 316.
Yeah, I would say not necessarily large in the sense of, 1,000 cc implants. I rarely ever see that. But
Right.
I would say a mismatch, like a D-size cup going into somebody that's a tiny, 5 foot, 105 pounds, that, so it's not on a numerical standpoint, it's a proportion issue.
And do you think that's because of the dissection is exceptionally hard, or there's more bleeding, or is it just, mechanically there's more trauma or issue?
I think it's mechanically very tight, and I think it's a contraction issue. I think a lot of times when I've seen this, the pocket has been under dissected, and with the intention of, well, I'm going to stuff the big of an implant is into this tiny pocket that I can find without causing any lateral descent or rising up high. And so it's a hand in glove type of situation,
For our viewers or listeners out there, just want to clarify a few terms. So capsular contracture is something that occurs when an abnormal amount of scar tissue forms around the implant. So whenever you put a foreign material in the body, whether it be a breast implant, a chin implant, any kind of prosthetic joint or anything, the body is going to react by putting some scar tissue around it. And that's normal. However, in some cases, you can have excessive amount of scar tissue forming around the implant. And in a breast implant, that excessive amount is termed a capsular contracture. And what can happen is that it makes the breast feel hard. It can make the shape of the breast look abnormal, and it can cause pain and discomfort in more severe cases. So as surgeons, we want to try to avoid that type of complication. And so we had talked about different ways that we do the surgery in order to minimize that risk. So the theory of why capsular contracture occurs in breast implants is the biofilm theory, which in essence is a theory that says that bacteria, small amounts of bacteria, can get onto the implant for whatever reason, and that bacteria stimulates the scar formation. So what we are trying to do when we're doing these surgeries is trying to minimize that effect from happening. So placing it under the muscle, which is something that we all generally do, seems to have a protective effect. And why is that? It's theorized that when the implant is over the muscle, that means that the implant is directly in contact with the breast tissue. And when it's in contact with the breast tissue, then bacteria can actually go through the nipple, which is an opening, go backwards and maybe seed the implant. That's one of the theories. So if you have the implant under the muscle, that doesn't tend to happen because the implant generally is not in direct contact with the breast tissue. Cleaning it with solutions, so antibiotic washes, betadine, which is a form of iodine that we use, also is theorized to kill the bacteria and decrease the rate. So I agree with what both of you said, that doing those things. Oh, and the funnel. So that is a way where we can insert the implant, in which it's placed through a disposable device that's sort of like what is that called? An icing funnel that you see that they use for topping cakes. You can actually squeeze an implant through that so it doesn't touch the skin. And that's what's termed as the no-touch technique. You don't have the...
Or gloves.
Or gloves, that's right. So your hands aren't even touching it. So that is theorized also to reduce the rate. So I think all those things are very positive, and we should encourage it.
The funnel, I think, is one of the most simplistic, most brilliant inventions in plastic surgery in the last 100 years. I mean, it's so incredibly simple, and it has saved so much time. It has such, great outcomes. And, I just remember years ago in residency, just trying to jam your, this thing through a small little tiny hole. It's like, yeah, well, you okay?
No, I just remember, I remember watching an attending taking this implant and using his fingers to try to shove it into a pocket. And I literally felt like the implant was already fractured or ruptured halfway,
Right.
just from jamming it in there. And the fact that we no longer have to do that is a blessing for sure.
Yeah.
The one thing I want to point out in his case, which really blows me away, is that over 80% of his implants were anatomic, and only 18% were round, which, I mean, who uses anatomic implants anymore, honestly? Do you?
No, I don't. But, for the time period in which his data was collected, and because
They were
he's in
very
Europe,
popular.
yeah, I don't think that's so unusual. I was never really on board with shaped implants, mostly because I didn't think that it gave the benefits that were purported, meaning the shape was actually all that different. And in my opinion, it gave other problems, such as rotation and now, as we know, a rare form of cancer that's associated with these textured implants. So I never really got onto that bandwagon, but this surgeon's data, I think, is consistent with the time period and where he was practicing.
What about smoking? He had over almost 10% of his patients were tobacco smokers. And I have never operated knowingly on a tobacco smoker for primary breast augmentation, ever. They might have lied to me, I don't know. But I have been pretty adamant that no patient should ever be on nicotine if I'm going to do a breast augmentation on them.
So you
Europe,
mean
Europe, right?
when you're doing the surgery?
Yep.
Okay.
He's in Europe, right?
Yeah, he's in Sweden.
I mean, it's probably a significantly larger proportion of smokers than Europe than in the United States, I would imagine. And if none of these are mastopexy patients, right? So,
Nope.
yeah. So, in theory, you're not making these big, large flaps where there's, skin to be necrosed. So, I that statistic doesn't necessarily surprise me.
How about you?
And
Do you operate on
my
smokers?
understanding is no. I would try to avoid it at all costs. I think, not.
So, getting back, yeah, I try to have patients stop smoking. I mean, for certain operations, that's a definite no-go, like a tummy tuck or a facelift. For breast augmentation, I will tell them with all, as with all patients, you're making an investment. You want this to go the best it can go, so you should stop smoking. I would assume that a proportion of my patients who say they've stopped smoking probably haven't stopped smoking. But I think it's generally a little bit more acceptable for a primary breast augmentation than for some of those other surgeons. But I wanted to get back to an interesting point about the type of implant. Do you guys still use shaped implants?
No. Do they even sell anatomic smooth implants out there? Is that even a thing?
No,
I don't know.
there's no such thing.
Yeah.
And for viewers, the texturization. So implants come in smooth or textured. Texture means that the implant has a rough surface on it, and what that does is, in the context of a teardrop-shaped implant, it prevents the implant from rotating, because once it's inside, if you have a smooth surface, that teardrop could be upside down, and that could cause some problems. So all implants are textured. So Sam, you don't use shaped implants. How about Sal? Do you?
There was a period of time where I used it for probably a year or two, and then I was very unhappy with the appearance. I think they're a little bit too stiff. I think you see a ridge up top where you're not supposed to. I think they distort themselves. And I actually believe that when it does develop a capsular contracture with a shape device, it actually looks a lot worse than it does with a round device, because the distortion of the pocket is so odd shape.
Yeah, I've never loved them, and I feel like I've taken some out recently, and they're a bear to take out, I think, just because they're so adherent. And I have had to be really, really slow and careful, especially if there's any sort of capsular contracture around them, which I've encountered a couple times. Like it's just to peel that textured implant off is very tedious for me.
Yeah, I sort of have the impression of texture devices that my daughter does when she orders something and doesn't like it. She says to the waiter, she's 11, "I didn't love this.
Wow.
I don't love them."
Let's talk about some of the other risk factors that are involved. He had a higher complication rate with patients who had a BMI of 25 or higher. Do you feel like that is in line with what you see?
I haven't tracked it, but I would say that in general, as a person has a higher BMI, their complication rate probably goes up. 25 is still a reasonable weight to do breast augmentation. I guess it depends on what kind of complications you're talking about. If it's sort of minor complications, yeah, I can see that. If the paper said 35 or higher, I could definitely see that to be true. But no, I haven't looked at my series, but I would say that's possible.
How about in Canada? Because I would say that this guy was in Sweden, so I would imagine that, just on stereotypes alone, that we as Americans are just, higher BMI population than the Swedish people. But in Canada, do you find the BMI to be comparable to Americans? Higher, lower, same? What do you think?
So from what I see coming from, um, you know, Southeast Michigan, where I used to practice, coming to Toronto, the BMI is definitely lower in Toronto. And, I would say that, complications related to breast augmentation, I don't think it's really changed that much. But I think for things like body surgeries, you probably have I've seen a lower risk of complications from that. Maybe not from breast surgeries, though. But definitely BMI is lower in Toronto than in Southeast Michigan.
He also noted an increase in complications with patients who had initial B or C cup sizes versus patients who had an A cup size prior to surgery. Do you find that to be the case?
I mean, if anything, I would say the opposite is true in my practice. I mean, I think going from an A to a D cup, thin skin, not a lot of extra breast tissue. You're going to see some rippling, some issues, potentially some bottoming out from structure. Small changes from a B to a C, C to a D. I think patients tolerate that really easily.
How about you, Larry?
Yeah, I would agree. I think that there's sort of like a spectrum, right? So if a patient is too thin, they're probably more likely to have problems. If they're too, large, then they're more likely to have problems. So getting a patient sort of in that ideal range is probably going to reduce your complication rate. But I mean, again, I haven't looked at my numbers so specifically. But what you said about the, A versus B or C, I don't think I see that.
How about implant volume range? She noted an increase in complications if the implant was larger than 370 cc's versus under 370. How do you feel about that?
Yeah, I mean, I that kind of goes along with what I was saying a few minutes ago. I think, the bigger the implant, the more weight, more potential for bottoming out. I think putting a large implant into a small space, going up dramatically in size, I think is associated with some issues. So yeah, I mean, I would agree with that.
What do you think patients can do best in terms of trying to avoid any complications for a primary breast dog? Like, what do you tell them? Hey, listen, this is what you need to do to minimize risk, to make sure everything goes smoothly.
So I would say, as a surgeon, you have to make sure that the patient is a candidate first. So, general health, as mentioned before, weight in the right range, make sure that they are not smokers or they're going to quit smoking. And then the important things are for patients to follow in your instructions. So you can get complications from patients not following preoperative instructions, and you can have patients having complications from having not following their postoperative instructions either, like trying to exercise too soon or not taking it easy after they've had surgery. But in terms of the size, choosing an implant that's going to work with their frame, just like Dr. Pacella said. Don't try to force an implant into a patient that won't fit into them, because you're going to be asking for trouble. And it's our role as surgeons to try to guide them through that process, to choose the implant that's going to minimize the risk of complications.
How about you, Sal?
I mean, it's the same sort of thing. I think, the last thing I would say, in addition to everything Larry pointed out, was, just understanding expectations about size and such. I try to use a lot of photographs and pictures and sort of model on things that patients bring in to show me. And I think that helps quite a bit to get realistic expectations.
Yeah. I think we should all take a trip to Stockholm, Sweden. I've never been there. I think it would be awesome to go visit this guy's practice and see what he does. I would love to sort of. I always love watching other surgeons. I always feel like I learn something from them. So I thought it was interesting that he decided to go ahead and present at this point. I don't know what stage of his career he's in, um, or why he decided after only 12 years. Like that's, I mean, I think all of us have practiced for longer than that at this point. So, I would like to pick his brain a little bit more. I appreciate him for publishing this. Thank you guys. I really appreciate it. Look forward to our next episode. And as always, thanks again.